Hello and welcome. It is with great pleasure to have you all here from around the globe for our second IFSO Integrated Health webinar. Today's webinar is titled The Role of Exercise in the Pre- and Post-Operative Bariatric and Metabolic Surgical Patient. My name is Tracy Martinez. I'm a registered nurse and program director at Whitgrove Bariatric Center in Del Mar, California in the United States. I am also the past president of the ASMBS Integrative Health section, and currently I'm the chair of the IFSO Integrated Health Committee. I will be your moderator for today's webinar. We have discussants and presenters today, very distinguished, and also represent different countries throughout the world. This is our strength of IFSO, and I hope that you will all become more involved in IFSO. I would like to start with introductions of our distinguished discussants. Our first panelist is Dr. Dale Bond. Dale is an associate research professor of psychiatry and human behavior at the Merriam Hospital and Brown Albert Medical School in Rhode Island in the United States. His research largely focuses on assessing and intervening on physical activity and sedentary behavior using both in-person and technology-based approaches in the context of bariatric surgery. Dr. Bond has been awarded grants from the NIH and other organizations to conduct prospective studies and randomized trials to advance these areas. His work on these projects has yielded him numerous publications, invited presentations at national and international scientific meetings, and membership to the editorial boards of SWORD and Obesity Surgery. Next is Scott Jamison. He is an exercise physiologist, having received his undergraduate and graduate degrees in exercise physiology. Scott's research interests focus on the areas of metabolic and exercise testing, energy expenditure, body composition methodology and analysis, and physical function status in older adults and patients with obesity. Scott serves as metabolic phenotyping laboratory manager for the Obesity Institute and Center for Nutrition and Weight Management located at Geisinger Medical Center in Danville, Pennsylvania in the United States. Our third panelist is Marcos Morales Oliveira. He has a master's degree in endocrinology and exercise physiology by the Federal University of Sao Paulo in Brazil. He's an educator in diabetes by the International Diabetes Federation. He's a clinical research coordinator at the Salet Institute of Medicine. He's a physical trainer and CEO of Berry Fitness. And with that, I will turn it over to Christina, who is our distinguished speaker from Brazil, and she will be speaking on the role of exercise in the metabolic and surgical patient. At the completion of her presentation, your screen will allow you to type in questions that we will then turn over to our panelists and answer those questions at the completion of Christina's presentation. Christina, you can take it from here.
Hello, I would like to thank you for the invitation. It's a pleasure to be with you, sharing some information about the role of exercise. And here we go. Well, according to Buchwald, bariatric surgery is considered the most effective intervention in morbid obesity treatment, with outcomes of more than 50% excess weight loss maintained beyond 10 years. However, even better than those who were not through a bariatric surgery, some goals achieved tend to soothe over the years, like weight loss and diabetes type 2 remission. The improvements in physical function and body pain also seems to decrease between 1 and 3 years after surgery. One of the hypotheses is about the amount of lean mass loss, as it is the greatest responsible for variations in energy expenditure at rest and declines in body functionality. This can lead to lack of engagement in physical activity programs, diminishing the weight loss, and result in worsening obesity and related comorbidities. The past decade Sorry, just a minute. During the past decade, skeletal muscle has been identified as a secretory organ, producing and releasing myokines which exert autocrine, paracrine, or endocrine effects. Those substances communicate with other organs, such as adipose tissue, liver, pancreas, bones, brain, and others. Some can present anti-inflammatory and regenerative functions. On the other hand, inactivity can lead to muscle mass loss and growth of abdominal adiposity, which stimulates the macrophage infiltration. This process results in chronic low-grade inflammation, coming out to insulin resistance, atherosclerosis, tumor growth, impaired bone function, leading to diabetes type 2, cardiovascular diseases, cancer, and osteoporosis. This explains, at least in part, why physical inactivity are strongly associated with chronic disease development. Many of these substances produced by skeletal muscle are dependent upon contraction and play an important role on the body metabolic regulation. Common barriers to exercise in patients with morbid obesity. Research has confirmed the benefits of physical activities and exercise. Active patients have a better quality of life, less surgical complications, lose more weight, and tend to maintain long-term success in surgery when compared to those who stay inactive. Unfortunately, they are not the majority, and science has been trying to understand why many of them stay sedentary. An interesting study found that common cognitions that served as barriers to exercise were related to how patients perceive themselves and the potential benefits of exercise. For example, if they saw themselves as non-sportive or do not believe the exercise to be useful for health, these negative cognitions likely prevent motivation to become an active person. In the general population, the three most frequently cited barriers to exercise are lack of time, energy, and motivation. Among bariatric patients, almost 30% reported lack of time, 30% refer physical limitations to exercise, often related to obesity, and many of them fear injuries due to their physical condition. But more than 78% mentioned at least one motivational barrier, like difficulty maintaining consistency of exercise behavior or making exercise a priority, and also lack of enjoyment. These can be important barriers and may contribute to weight gain or troubles losing weight, which can worsen their general condition. Almost a quarter of participants in this study reported that their bariatric facility did not provide service to help them with physical activity or that those services were not helpful. At last, few patients also referred lack of stamina, diet-related problems, or even the water. So what can we do to help our patients to overcome those barriers? It looks like having a multidisciplinary team is the key point to support the patients. Providers should ensure that all staff are educated on common barriers to exercise, such as perceived lack of time and motivation, and how to exercise in the presence of physical limitations. The whole team should receive training on how to assist patients in finding ways to overcome these barriers. Next, we present some tools that can help them with the main barriers we've seen before. As Charles Bruxton said, you will never find time for anything. If you want time, you must make it. If you really don't want to do something, you have to organize yourself. The first step is writing down your daily tasks. You can observe in detail where you are investing and where you are wasting your time. The second step is to choose the activity and the best time for you, and then include it in your schedule. If it could be before you're starting to work, at lunch, or even after your work, for example. The third step is to design an action plan using specific steps. Here is a model you can use. You're going to describe the main task, then steps you have to take to reach your goal. For each step, you will answer 7 questions. What, where, when, why, who is involved, how you're going to do that, and at last, how much you're going to spend. For example, let's imagine that a patient called Mary decided to join a gym, and we ask her to do this action plan. She will start looking for a gym near her work, so the question what and where are done. She must choose the exact day and time to do that. The question why is essential to keep in mind the importance of each step. If there is someone else involved, or if you want to enroll someone to make sure you will accomplish your task, write it down. Sometimes you will have to plan how you're going to do this. And finally, what is the budget or how much it will cost. As we saw, lack of motivation is the most frequent mentioned barrier to exercise among bariatric patients. So we have to pay real attention here. In the first place, we must try to discover where it came from. They may say they don't like some specific type of physical activity. Maybe they have had bad experiences that could be related with body pain, shame, or failure to reach their goals in the past. Some of them just don't believe in exercise benefits, or they can fear injuries. Based on that, what can we do to help? Professionals of mental health are fundamental here. Counseling face-to-face or support groups can teach a lot about exercise benefits, strategies, and how to develop healthier mindsets. Physical activities shouldn't be too complex that people can do it, or too simple that do not stimulate them. The trainer must be aware to the patient's preferences and be able to show many kinds of activities. The first step is keeping the patient in the physical program, no matter if it's not sufficient to change body composition in the beginning. Lack of energy could be related to diet, sleep, stress, low physical fitness, or other health condition. The patient must be assessed by the multidisciplinary team, but most of the time it is just due to the low calorie intake or low physical fitness. Physical limitations. The patient must be assessed by a doctor who can address the best treatment. It is perfectly possible to develop a training program along with a physical therapist, avoiding body parts in pain and strengthening it at the same time. It's very important to find out how much the patient knows about the benefits of exercise, as well as the disruptive effects of physical inactivity. Here is some enlightening questions to find out from where you must start and to create a positive environment about the future. We can use their answer to motivate them during the process. In addition, we must show them strategies to succeed and make them feel confident. Optimizing physical fitness in the preoperatory patient. There are essential reasons for the bariatric patients to start a training program as soon as possible. Some studies have shown that patients waiting for bariatric surgery are prone to gain weight, increase comorbidities, and raise mortality rates. One of these studies showed 1.57 of death in 22 months awaiting for surgery, while this Brazilian study pointed more than 8% in 24 months. Reduced cardiorespiratory fitness levels also have been associated with increased short-term complications after bariatric surgery. Therefore, cardiorespiratory fitness should be optimized prior to surgery to potentially reduce post-operative complications. The muscle mass loss, as we saw earlier, can also compromise body functionality and desirable fat loss. So patients who start a proper physical program before the surgery can minimize the effects of muscle loss. Morbid obese patients involved in a physical program right before the surgery have shown improvements in lipid profile, fasting glucose, blood pressure, and functional capacity. Besides that, exercise favors weight loss and promotes a better quality of life. Benefits of exercise in weight loss and maintenance. The first reason people join an exercise program is to lose weight, and science has found it can happen as long as people reorganize their eating behavior, lifestyle, sleep habits, and take care of mental health. This review has shown exercise can decrease body fat, increase glucose utilization, reduce resting blood pressure, improve lipid profile and functional capacity, enhance vascular condition, increase bone mineral density and gastrointestinal transit speed, reduce metabolic syndrome and cardiovascular disease risk, decrease depression levels, reduce discomfort in people with low back pain and arthritis. In addition, exercise has proved effective for decreasing premature all-cause mortality. Guidelines to exercise prescription. According to American College of Sports Medicine, a program of regular exercise must include cardiorespiratory resistance, flexibility, and neuromotor exercise training. They recommend engaging in moderate intensity cardiorespiratory exercise training for at least 30 minutes 5 days per week, or 150 minutes per week. When possible, vigorous intensity cardio exercise training for 20 or more minutes 3 times a week, or a combination of both intensities to achieve a total energy expenditure of 1,500 kilocalories per week. Still, there are other studies and data from National Weight Control Registry that suggested individuals might need to expend more than 2,000 kilocalories per week in moderate intensity exercise in order to lose and/or maintain weight loss. However, it seems that approximately 50% of patients are able to reach that goal at least in 12 weeks of intervention. The good news is that 80% can reach 1,500 kilocalories per week in the same amount of time. But there was no difference in weight loss or fat mass loss between those groups. The same occurred in this study, where parameters like heart rate variability, blood pressure, and body functionality improved, but body composition was not statistically different between groups. Especially for bariatric patients, the strength training is mandatory. The recommendation is 2 days per week or more, moderate intensity for 30 to 60 minutes. The patients can start with 1 set, going to 3, as long as their physical condition improves. The load must be something between light and moderate in the beginning, allowing them to complete 8 or more repetitions. It is always important to remember that those guidelines are just a starting point and must be adapted to each patient's reality. Recently, Our group have made a systematic revision of the impact of strength or combined training in bariatric patients. A combined training is a physical program composed by aerobic and strength training. We could find out some interesting outcomes. First of all the interventions generally last just 12 weeks, which is a short time to get strong changes in body composition. However, half of them showed a slight improvement on weight loss. Even in interventions where the aerobic exercise was not present, cardiorespiratory fitness enhanced as long as the skeletal muscle participates as a primary route in oxygen extraction and consumption. Patients that have done resistance training lost less muscle mass than the control or aerobic groups. However, the dynamic and static strength raised in all resistance training groups, showing 22 to 72% of improvement. This improvement impacted positively their body function. Then we realized that longer studies showed better outcomes. In this 36 weeks intervention study, 30% of the resistance training group didn't show any muscle mass loss. Probably they lost muscle right after the surgery and recovered through the strength training. But the main point here is that the group who didn't exercise lost 50% more muscle when compared with training group. In the same study, the lower limbs strength raised 178% and upper limbs 121%. This outcome is very important as long as body strength impacts the autonomy in activities of daily living. American College also recommend neuromotor exercise, which is especially relevant to bariatric patients, as long as they underwent sudden changes in their body center of gravity. So on 2 or more days per week, they should perform neuromotor exercise for each of the major muscle groups, involving balance, agility, coordination, gait improvements, and other motor skills. Taking into account that limb mass loss combined with physical inactivity can result in joint range decrease, a flexibility program must be implemented at least twice a week, but the best results come from everyday session. So how do we start? By the time the patient gets the medical discharge, what kind of situation do we have? Generally, the patient lost between 10 to 15 kilograms, where 30 or more % is muscle mass. This could result in bad posture, lack of strength, lack of motivation, cardiorespiratory fitness is weak, and the energy intake is low. So what do they need? First of all, we have to restore the normal life, giving them conditions to accomplish daily tasks, recovering the body functionality, muscle mass, cardiorespiratory fitness, and try to accelerate the fat loss. After a good physical evaluation, we can start neuromuscular adaptation, where we're going to work on movement control, offering the opportunity to a wide variety of exercise and equipment. The aerobic training must be of low impact, avoiding injuries or bad sensations. We must remember that the impact of 5 kilometers per hour on treadmill or walking equals to 1.5 times the body weight. So let's start slowly and break the cardio in 2 or more parts if it's necessary. Our goal here is to keep the patient training. The second step is to focus on muscle mass recovery as long as it is associated with energy expenditure, which can contribute to long-term weight loss. Muscles are also responsible for mechanical shock absorption and for skeletal support, playing the main role in body posture. Its metabolic and physiological role is vital, regulating many important organs and tissues. When the patient reaches the normal percentage of muscle, we can start a power training. What is this? Power training is a strength training designed to improve explosive power. This is pretty useful since they are very related to daily living tasks. Standing up, climbing stairs, pushing and pulling, lifting weights are considered power movements. It improves body strength and cardiovascular fitness, raises the caloric expenditure, and preserves muscle mass. We know that impact can improve bone and cartilage density, so we can start slowly to raise the impact whenever it's possible, of course. Finally, when the patient reaches normal physiologic parameters, we can safely focus on raising caloric expenditure. Some patients will never meet this point, and there are plenty of physical activities to keep their health. Other patients will be able to choose a high-intensive interval training, play their favorite sport, running, biking, or other pleasure and vigorous activity. So, is that all? The patient join a good physical exercise program 2 or 3 times a week during 6 minutes, and all that is related to physical activity is done? Actually, it's not. Studies have shown that even people who exercise regularly can present increased mortality rates if they spend a lot of time in sedentary behavior. This study followed more than 120,000 people during 14 years. The subjects were divided in 2 groups, people who used to spend 6 or more hours sitting, and a group who spent 3 or less hours sitting. They found that even who were engaged in physical activities but used to remain seated for 6 hours or more had a mortality rate of 20% for men and 40% for women. However, people who are not engaged in physical activity and used to spend 6 or more hours sitting showed 48% of mortality rate for men, and for women the rate was 94%. That's a lot. Those data mean that exercise cannot fully overcome the harmful effects of long periods of physical inactivity. Therefore, changes in lifestyle are so important as physical training program. Takeaway points. The effects of bariatric surgery will not last forever, so a multidisciplinary team is indispensable. We must discuss deeply the benefits of an exercise program with our patients, as well as the harmful effects of physical inactivity. Meet your team often to discuss patient cases and design strategies together. Create support groups where people can share their difficulties. Create events to promote physical activity. Recently, the Bariatric Brazilian Society have made a national walk-in to fight obesity. At the same time, many cities have joined the event. It was very, very good. The staff must be trained on the main barriers to exercise. The physical program must include changes in lifestyle. This is very important. The first step is prescribe exercise, focusing on keeping the patient training. The second one is to reach physiologic goals. Remember, the best way to teach is through example. So let's move.
Thank you, Christina. That was a tremendous presentation. I just wanted to add that besides Christina being an exercise physiologist, personal trainer, and working with bariatric patients in Brazil, she has published throughout the country and internationally, and she is a one of our newer members of the Integrative Health IFSO committee. So she'll be available to you as a committee member, and we'll make her email available. But I just want to congratulate you on a great presentation.
Thank you very much.
So now it's time to take questions, and as you can see from your screen, you can type questions into the computer, and we will see them here, and then we will be able to read them. And then I'll have our panelists comment on those questions as they come in. So we do have a first question, and I'm going to ask Dale to respond to this. The question is, what monitoring devices do you suggest for bariatric patients to use to help monitor or motivate them?
Well, there are a number of different commercial trackers that patients can use. Most are worn on the wrist, so Fitbit, there's also the Apple Watch. There are several different types of fitness trackers. Any of those can work in terms of motivating. Some of them have different functions in terms of whether or not they're measuring physical activity or how they're measuring physical activity. Some also have the capability to measure sleep and also sedentary behavior.
Okay, that's wonderful. I have another question here, and I'm going to ask Scott this question. Do you do pre- and post-operative body composition analysis? And if you do, what method do you use?
Yes, so at our particular practice, we do decide to do body composition. We feel that the patient feels they get a little bit more value out of it than looking at just a particular weight score or looking at a BMI value. So you do measure pre and post-operatively. There's a number of methods out there currently that you can do body composition with. Some are a little bit more practical than others. I think the two that are widely used in most practices would be multi-frequency biological impedance analysis and air displacement plasmography captured via the bod pod. They have their pros and cons between the two. I tend to think that biological impedance analysis is a little bit easier to administer. It's a little less invasive on the patient, doesn't have as many contraindications, and it's certainly less expensive technology too. So that way we can kind of track, with a particular weight loss, are they preserving the skeletal muscle that we hope to see with a rapid weight loss, and hopefully we're seeing more of a fat mass loss with that as well.
Wonderful. I have another question that came in. Is there a recommended guideline to follow regarding pre- and post-operative physical activities for our patients? Is there anything, I'm assuming from this question, she wants to know if there's any international guideline or guideline in one of the societies. Christina, do you want to answer that?
I can take it. Actually, American College has the whole guidelines for obesity and other comorbidities, but we don't have guidelines, for example, from American College for bariatric patients. Our research, and in many places around the world, is to produce sufficient research to do that.
Okay, great. Another question coming in is, how long after surgery should a patient begin strength training, a strength training routine? I'm going to pose that to the entire panel, but let's start with you, Dale. Do you have some thoughts about that?
In terms of strength training, I know in terms of the practices here that they wouldn't recommend that until at least 2 months afterwards, depending upon the type of strength training that's being performed. But I would probably defer to Chris on that one, who actually does those types of interventions. I don't do those.
Well, actually, in our service, we used to wait for the medical discharge. And if there's not complication, actually a strength training is any kind of training you do with a little bit of load. So we can do a light mode even the day after. Of course, we will not do that, but we are able to raise 1 kilo, for example. So the point is, who is the patient, what the best exercise he does. There are an analysis to do after the starting this program, but usually we start on 30 days after surgery.
Okay, great. Another question, and I'm going to pose this to either Dale or Scott, whoever wants to take it. What role does bone density monitoring play in our patient care regarding the specialty of exercise?
Scott, go ahead.
Okay. So can you say the question one more time, Tracy?
Sure. The person wants to know what role does bone density monitoring play, if any, in relation to assessing a patient's fitness or progression with fitness and exercise.
Okay. So with the bone mineral density, there's usually one way to capture that in most clinics, and that's through DEXA. So with that, it's a little bit more of an expensive tool. I think they run for about 6 figures or so. So from my experience, not many clinics can afford this type of machinery. There's a lot of restrictions as well on certain legislations on how you can operate it within certain states. Like for example, the state of Ohio, you have to be licensed to operate it. Whereas Pennsylvania, where I live at, we don't need to be operated. I don't really have a lot of particular experience on capturing this in this kind of a patient population too. Just to do with the body sizes, you actually need a particular DEXA scanner to be able to accommodate the certain BMIs or above too. So if you're looking for the bone mineral density content, I would say that it's not really. I mean, it's an important factor too, especially if you consider the risk of the patient. If somebody that's postmenopausal, they're above the age of 65, et cetera, too, then I would say that that's going to be an area of concern. But I would say the composition itself, the amount of fat mass, the amount of skeletal muscle mass is going to be more important for us to look at, practicality-wise.
Great. I have another follow-up question from someone in the audience, and I'll ask Dale this. They want to know, how often do you recommend checking body compositions in patients following surgery? What's the frequency?
Actually, I don't measure that, so I think that's question would probably be better for Scott.
So we typically measure them at least about a year after their surgery date. So we do like to get a pre-measurement about 4 to 6 months prior to them actually having surgery, and then a year or so beyond. That's typically when I meet with the patient again for our standard of care practices. Depending on what the patient sees, if they like to get it done more often, we can certainly do that as well too, but it's usually about 1 pre-op, 1 post-op, and like I said earlier, we usually measure them via bioelectrical impedance analysis due to its quick, rapid measurements that we can get from the device.
Okay, great. Here's another question, Christina, for you. The question is, are there guidelines of rates of percentage of free fat mass people might lose after bariatric surgery? I think the question is there ranges which you would think is normal and other ones that you might be very alerted to that could be problematic?
The percentage of muscle mass loss, is it?
Yes, yes.
Some studies show that up to 33-36% of lean mass loss could be problematic, but there are also other things you have to pay attention. But generally, up to 35%, we have to pay attention.
Okay. Another question, I'll open it to the panel, and the question is, will the parameters of physical activity change according to specific bariatric procedures, or will they remain the same for all procedures, whether they're malabsorptive or restrictive? You want to take anybody?
Okay.
I mean, I'll take it if no one else.
Okay.
Okay, go, Scott.
So I don't think it. I mean, it would really depend too on one, if it was an open or laparoscopic procedure, then you would have to kind of look at, with strength training on restrictions regarding that as well too. But I don't think that there's any type of pre-planned, if you get the Roux-en-Y versus you get the sleeve, this is what you do for the exercise. I mean, it comes down to the individual level too. I mean, the end game is for us as professionals to teach them regarding exercise and weight management. But if you have somebody that's has significant amount of comorbidities, but specifically things such as cardiovascular pulmonary disease, you kind of have to treat that first and then go to the end goal of the weight management process. You can't just jump ship out of that order, sort of thing.
Right. That's great insight. Thank you for that. Here's another question that says some insurance companies require an exercise regimen or evaluation in order to get their surgery approved. What do you do when a patient has severe obesity with a BMI greater than 50 and some disabilities? What do you do in this case, and how would you prescribe that for a patient with severe obesity with a BMI greater than 50? Christina?
I think we can do a lot, for example, with the patient laying down, just moving the legs, the arms. There is a lot of another devices, for example, electric stimulation. You can use it to raise the caloric expenditure. So we can do a program with this kind of patient, even with that weight.
Okay. Next question. In a preoperative setting, what is the recommended minimum number of weeks for an exercise program with the goal treatment of having some weight loss? So ideally, do you want to see preoperative weight loss? And how many weeks ideally would you like to work with the patient to optimize them before surgery?
Actually, it's individual, but I think for studies with 12, as I said, 12 weeks, some of them show difference in body composition, others not. So I think more than 60 months training is enough to show many difference.
6 months?
Yes, up to 4 months, it's enough. The point is, the patient have a disability. What can I do? I reach some steps with once another people can do it.
I think too that is as early as you can engage. Start so
2
immediate.
months.
Yeah, do you agree with that, Dale?
Yeah, well, and I think that we should probably be cautious in terms of just focusing on exercise as the way to achieve preoperative weight loss. It would have to be in combination with some sort of diet regimen. And so I think it's also more important to think about exercise, particularly preoperatively, in terms of trying to develop a habit that's going to carry over postoperatively.
Right. I have another specific question that's interesting. This person wants to ask the panelist, in a week, how would you split the strength training and cardio? So how would you prescribe that? So obviously cardio and strength training both are important after surgery. What would be a prescription or a guideline for a patient to do per week?
The first step is to see how many time the patient have available to exercise. Sometimes he's going to the gym 2 times a week, and they have like 6 minutes. So I have to put the cardio and the strength training at the same session. If they have 5 days a week, I can share it, and that depends on the fitness condition of this patient too.
Okay. Another question is that patients with arthritis often benefit from exercises such as swimming because of their pain or mobility and walking issues. What other exercise would fall in that category, Scott, besides swimming, since not everybody has a pool accessible? But what else would you prescribe with somebody who has severe arthritis of the weight-bearing joints?
That's a good question. So typically, if you're looking for aerobic exercise, then you can kind of go through arm ergometry. That's usually a very ideal thing for patients that have, degenerative arthritis in the knees, where they're bone on bone, or they need a hip replacement, et cetera, too, where they can't tolerate much low weight bearing activity standing up. So if they're seated down, they're able to get the cardiovascular exercise in that way, then that would be great. You can give them chair exercises for resistance training, and that's often when we give a lot of our patients. We're doing a full body workout from the chair. You can use wrist weights, instead of hand weights, depending on the significance of the arthritis in the hands as well. Just simple modifications to do. That's a very common comorbidity that we see with a lot of our patients is the degenerative arthritis too, and these are the kinds of things that we prescribe to them.
Right, very good. Dale, another question came in saying body image is often a barrier for many people to participate in activity. Do you have any tips to share to help patients who might be intimidated to do physical activity because of their perception of body image, particularly either preoperatively or early postoperatively before they've had significant weight loss?
Yeah, so I think there are a few things that could be done. One is to prescribe more of an individually focused program, and so something that they can do with someone that's a source of social support, either that's close to them, that will make them feel more comfortable, or you could do it with a group of bariatric surgery patients where everybody is more, I would say, exercise naive. Or there's also programs tailored, for example, like yoga programs that are tailored for individuals of higher weight.
That's a great suggestion. I have another interesting question. So the question is, what would you recommend for someone with significant loss of muscle mass after surgery? So meaning they've already, unfortunately, lost more muscle mass than we would like to see. What do you do when that occurs? It's already occurred. So what is your suggestion for that individual? Dale?
Well,
Oh, Christina, that's fine.
no, we can
I'll
go
probably
there.
go to Christina and then
No,
follow
go ahead.
up with Dale.
Okay. I'd like to think that the strength training is pretty enough to do that, along with the right nutrition. They have to be with the nutritionist always and do the strength training. The strength training, people think that strength training must be going to the gym, but you can do a lot with elastic bands, with things you have at home. For example, little packages, and just sit and standing up off a chair is a kind of strength training. So it's simple to do, and you must start with baby steps. But I believe strongly that strength training is the key point.
Dale, any follow-up to that?
No, I think that was a great response. I don't have much to add to that.
So if the patient has not maybe kept up with their protein and exercise, and then they have significant muscle mass loss, how much of that can be rebuilt after that initial rapid weight loss?
I don't think I have this answer.
I guess the question is, can you make a difference, or is that opportunity lost?
Oh, I think it's possible. I don't know if I understand very well the question. If it's possible to get the muscle mass again, is it?
Right. So the question is, this patient has lost significant amount of muscle following
Yes.
surgery. So, hypothetically, maybe it's a patient that kind of disappeared, came back, they've had significant muscle mass loss. What do you do with that individual?
Strength training and the proper nutrition. The point is how much muscle, because your body needs that muscle when you are very obese. Then when you lose weight, you don't have that amount of muscle mass again. You need less muscle mass to support your body because it's lighter than before. I don't know if I
No, that's good.
answered.
Dale, anything to add to that?
No, I don't have any.
Okay.
Maybe Scott does.
Yeah, so I think that the key is definitely resistance training, but it would have to be dependent upon the degree of malnutrition. Depending on what their overall strength would be, depending on how much resistance training can actually do for that particular person. I don't think that they should stay away from keeping up with their activity, or just in keeping up with activity throughout the day. But I wouldn't engage in much structured cardiorespiratory fitness until we can kind of minimize the caloric expenditure and really focus on building the muscle, which we want to get ourselves out of that particular situation.
Right. Marcos, I'm sorry, I just saw that you joined us. I wanted to ask you the next question. How do you motivate a patient who has returned to you and has had weight regain? How do you motivate that patient when they come back to you?
Hi. It's important to remember that there is no ideal activity for weight loss. The exercise that promotes great fat oxidation and therefore better results in weight loss are those in which patients can improve an optimal intensity during its execution. This fact will increase the post-training oxygen consumption and will directly influence the increase in energy expenditure in rest periods. So for motivate the patient, I think that the awareness of those is very important to do.
And would you increase the frequency of following that patient who has had some weight regain? Would you prescribe them seeing an exercise specialist more often, or what would be the prescription for that?
Yeah, the exercise program should be planned for the short, medium, and long term, and need to start slow and with progressive increases in the intensity, but always respecting the limitation for each patient.
Great. Okay. And Christina, this question has kind of been touched upon, but it's specific. The question is, how do you fit into your patient program pathway? When does the patient develop their exercise program, and how do you initiate that, both preoperatively and what does follow-up look like in your regular pathway?
In the preoperative, I think the earlier he starts, it's better. And so it's important to have at least 4 months after, but less than that, it's better than nothing. After 30 days, or when the surgeon release the patient to do the training, we started to evaluate them, and we do it very individually. So we start to always thinking about maintaining the patient training. Start slow with baby steps, avoiding complex exercise, doing things that he likes. He's looking at his preferences, and then as long as he is gaining physical fitness, we start to go deeper to heavier weights and things like that.
And how often do you see the patient post-operatively? Monthly, bi-monthly? How often in your pathway do you typically see your post-operative patient?
Actually, our patients, we do the training as a personal trainer, so we see them like 2 or 3 times a week.
Oh, wonderful. Okay. Marcos, this question is
Tracy, I'd like to complement the
Sure.
answer. This is very important. The process of physical adaptation is slow and happens gradually, which requires patience and discipline. I think that's the key point for the success.
Great. The next question, Marcos, is can we prescribe isometrics for people with severe obesity that have hypertension?
Yeah, there is a lot of papers related to the benefits of the isometric contraction for the hypertension. Yes, it's a very important.
Great. Scott, another question here. What exercise is recommended for patients who complain of saggy skin or lack of muscle toning following their weight loss?
So what I usually tell patients when I get this kind of question too is that resistance training can certainly help with the saggy skin, but skeletal muscle and adipose tissue are two different types of composition. So if you lose one, you can gain a little bit in the other too, but it has to do with the quality of the skin too. The skin is very pliable and adaptable to many sizes and shape, but it's just like a rubber band. Once it reaches its point of maximal stretching, it really can't go back, and that's when you really need more of the surgical intervention to kind of help. So what I usually say, resistance training can only help, can't hinder things.
Okay, great. And Dale, what kind of physical fitness test do you think is important to do with the patient to evaluate them preoperatively? We talked about body composition. Any other physical tests that you would recommend for evaluation?
I think that there's some physical function tests that we could do, like, for example, a 6-minute walk test. But in terms of cardiorespiratory fitness, I think that Scott and or Chris would probably have the best idea of that.
Do you want to expand on the 6-minute walk test? Yeah. What that is?
So it's a standardized test of physical function and also physical fitness, but there are more direct ways to actually assess cardiorespiratory fitness. But it would you would have to have a space for it, and it would be just walking at a self-selected pace, however as fast as they can, and you would time it for 6 minutes to see distance travel.
Do you check heart rate or anything else in that test?
Not in that particular test, no.
Okay. Scott, do you have anything to add to that?
I mean, you can certainly do a whole slew of, cardiorespiratory fitness assessments prior to evaluation with the patient. In an ideal setting, that would definitely be recommended. You can do submaximal or maximal VO2 tests if you have the capability to actually measure that, which we do at our particular lab. We have the capability to measure that. If you're looking for more of a field test, you can do like a step test. You can do the Rockport 1 mile test. I mean, there's a numerous amount of tests that you can kind of do to assess an estimation of their aerobic capacity.
Okay, and Christina, in your practice, what pathway do you follow in the preoperative evaluation? So we heard of the different options. Is there any specific thing that you do regularly for your patients preoperatively to evaluate them, pre and post-operatively, I guess?
We used to do the bioimpedance and then CT scan test, strain from the upper limbs and lower limbs. And the other tests we do with the cardiologist on the treadmill. So we think it's safer. In Brazil, they not recommend to do in the lab. They do it with the cardiologist.
Okay, so we have two
Tracy,
final. Yes. Yeah,
Tracy,
great.
I would just add too that we should probably also be concerned about what they're doing in their free living environment. So using accelerometry or an objective activity monitor to actually see what they're doing on a daily basis would also be a good test.
Yeah, great,
Yes.
Great comment. That's a great comment. Yep. So we have two more questions left. Marcos, I'll ask you this one. Do you, quote, prescribe an exercise plan in your patient population that's individualized for each patient? So do you individualize the exercise plan for your patients?
It depends, because here in Brazil, we have our public health, that the patient have no conditions to pay for the service. So in this case, we must to standards the prescriptions of the exercise, but always we emphasize that the training in the group training is a very important for the patients obtain the success. when the patients have the conditions for pay and particular service, then, like Christina said, we engage in the personal training service.
So you have two options for them, group classes or personal training, and they can access either. Okay.
Yeah.
Thank you. And then the last question is, do you think that any certified exercise specialist should be working with our patient population, or ideally would you suggest that this person be specialized in treating patients that are affected with severe obesity? I'm going to start with you, Scott, on that one.
So I think it has a lot to do with the individual's background and where they came from. So as we know, exercise physiology is a very broad field. You can kind of segue into different things. You can do biomechanics, you can do employee health and wellness, you can do cardiac rehab, pulmonary rehab too. I think it serves credence to have some kind of credential to be working with patients with either semi-controlled or controlled diseases. For me in particular, I am a certified exercise physiologist. I'm not a clinical exercise physiologist. So if there's a patient that I typically work with that is a high risk for an adverse event, I will just simply say that we can't do anything, that they would write the referral for physical therapy, where they need kind of a little bit more in-person supervision. Monitoring while exercising too. I would say that's not very common, at least in our practice. I think that's only happened a handful of times, and a lot has to do with the range of motion orthopedic limitations that you typically see with our patients with the severe obesity.
Great. Anybody else have a comment about that?
No, that's perfect.
Well, I have a comment about it. As a nurse, I think that your specialty of being specialized in exercise and physical fitness for our patients is a huge asset. So I'd love to see your field grow. And I do know that sometimes it can be problematic for numerous reasons when patients seek an exercise specialist of any kind or trainer that does not have specialized training in this disease. I think from an empathy standpoint and a safety standpoint, I think there's a risk. So we need more of you, and we need more of you in our programs throughout the world. So we've answered all the questions. I am very grateful for all of you and your expertise to be available for everybody around the globe today. I wanted to mention that this presentation will be archived on our website, and if you haven't looked at it before, IFSO has a website, and Integrative Health has their own web page. So please visit that and email me if you'd like to be more involved. And again, I would like to thank everybody for their participation in the audience, and most importantly for Christina for a wonderful presentation, and for our distinguished panelists. Thank you all very much.
Thank you very much.
All right.
Thank you.